We're here at the International Conference in Kuala Lumpur. It's the Conference on Pathogenesis, Prevention, and Treatment and Prevention. And we're here with Carl Dieffenbach, who's one of the directors of the NIH, the NIAID, DAIDS.
Yeah, the Division of AIDS at NIAID.
Which is the National Institutes of Health. So there's been a lot of information that came out at this conference. Of course, the World Health Organization guidelines and of course this pre-conference on the cure. So let's start with where you want to go first, because I want to make sure that we cover all the material that would be important for your
Well, let's start with the talk about the guidelines. I think the release of the WHO guidelines is an important step. It brings the WHO guidelines in many ways in alignment with what the HHS, the Health and Human Services USA guidelines, have already said, that treatment should begin at a CD4 count of 500 or below. The interesting thing about the guidelines are that they called out 4 distinct target populations of people who were living in serodiscordant couples, pregnant women, people with, I think, TB, children under 5, and what was the other one? It'll come to me.
Okay.
It was on the tip of my tongue. Pregnant women. Anyway, they're in the guidelines. And that's important because those people are to be treated immediately upon diagnosis. So what this raises immediately is the question of, we go from currently 17 million people globally who need treatment for their health according to guidelines to now 27 million people globally. So we've had, we're doing reasonably well as a world. We're getting close to 10 million people who have been on therapy. What this really does then point to the tremendous gap in what we'd like to do and what we can do. I think that is one of the major things about this conference. Being in Malaysia with a reasonably small HIV/AIDS epidemic, I think it's right around 100,000 or a little bit less, and they have about 15 or 20% of those people on treatment. So this is an example of a middle to high income country that could essentially get everybody on therapy. Whether or not they will have the intellectual capacity in terms of the physicians and the healthcare system, as well as the finances to do it, will be an important question.
How do you think that, I know that we just had this talk this morning with Dr. Hun, I believe his name was, from Cambodia, and how they've made such an impact because they hit the ground running early rather than waiting until it became really an epidemic. And so they had a good return on their investment, I think. But how do you think this will impact the prevention aspects? Because when we get on, that's what we're looking for, is the community health.
Well, there's 2 issues here. Treatment is prevention, because if you lower the number of people who have a viral load that can actually transmit, you will improve that aspect. The thing that we have to realize is that people who are acutely infected don't often realize they're HIV positive. And I think
even
that
in our country, in the United States,
it is a global problem of how to diagnose acute HIV infection. There are people who are asymptomatic and are newly infected. How we can improve that, because those are the people that have the highest viral load that tend to transmit, because nobody wants to transmit. They just are unaware of their status. So it really gets at, if you're in a high-risk population, test at least twice a year. And making that something that is rewarded in society and not stigmatizing is the challenge for all nations.
I think the gentleman from Cambodia was saying that initially they rolled out their program with specific sites where they would have people looking for HIV testing and treatment, and they said it wasn't cost effective and people didn't come, and I think we learned
stigmatizing.
Yeah, it was stigmatizing. So they now they go to the normal, regular public health clinic, and it seems to make a difference.
Right.
So as far as the cure, we talked about pathogenesis to
right.
cure.
So we had a pre-conference workshop that was organized by Steve Deeks and Francois Barré-Senoussi. Everybody should have a Nobel laureate in their camp. that really spent 2 days focusing on the state of the science. There were some very interesting aspects of the conference, and one of the issues on cure, it has become so overhyped. It's every day you read in the newspapers that the cure is coming, the cure is tomorrow. We're probably years and years and years away from a cure, a true cure. And so we have to realize that we should probably start changing the language because we're over-promising. We need to start talking about tackling persistence, tackling latency, creating situations where people are controlling their viruses naturally through immunization, through other treatments. But to overpromise on a cure, I think ultimately could be detrimental to the field. At the same time, we have to realize that if we can't at least have the aspiration of working toward a true cure that is safe, scalable, and less invasive than current level of antiretroviral therapy, we will never create a system where cure can be part of the equation, where it can be part of an AIDS-free generation. If we cure 1,000 people, if we cure 10,000 people, that is never going to impact the global epidemic. We have to have a cure that's scalable the way antiretroviral therapy is.
I think they had a meeting at the FDA regarding addressing patient concerns, or
that was.
But I think it's really just about the fact that there will be trials that people will be involved in that may be very preliminary, and I think that no one should ever think that. And maybe you're right. Maybe we shouldn't call this anything to do with a cure. It's a process by which we will getting to the things which will add up to a cure over time.
Right.
It's a scalable thing. So the other concern that I have is, you cover prevention. I mean, is there anything that you feel at this conference will be highlighted that might be important too?
Well, there's a session later in the week on the future for HIV vaccines. And there is a fair amount of interest and excitement in the field of HIV vaccines because we have, for the first time, 2 very strong parallel tracks of activity that have really interesting science behind them. We have the broad neutralizing antibodies, which if you take a couple of them and put them in combination in cell culture, will essentially inactivate 99.9% of all the circulating strains in the globe. Now, if we can only figure out how to make an immunogen that will reproducibly trigger the production of those antibodies in a human being upon vaccination, we'll be somewhere. But we know what we want. We have a target that we know what we want now.
Where we want to go.
Where we want to go, and we know what the starting material is, and then it's that magic black box in between that is what really excites researchers. There's been progress made in terms of at least some people starting to define a pathway from the beginning to the end. So there'll be some initial trials over the next year or two. So Dennis Burton is going to talk about that in the session. And then a study that occurred here in Asia, in Thailand, RV144, the long-term follow-up from that is going to be reported on in the next steps with trials in Thailand and trials in Southern Africa. So I think that from a prevention research agenda perspective, that is one of the more interesting sessions here at this meeting.
Are there any others working on that as apart from Dennis Burton at Scripps? Or
yes. Within the United States, there are a number of key laboratories at the NIH and at Duke University and at Rockefeller. In South Africa, Lynn Morris and her team are working extensively on that. There's groups in Japan working on this. It's pretty much a global effort.
Is it a collaboratory?
They're not formal collaboratories, but they all exchange reagents and work very closely together. While it's competitive, it's also cooperative. And then the other component of all this is linked into structural biology. So every time somebody gets a new antibody, they determine the 3-dimensional structure of the protein, figure out how it interacts, how it binds, determine its primary sequence. And that is a critical element in terms of designing structurally the immunogens.
Well, I don't want you to leave here before you cover everything that you wanted to hit on, but I wanted to make sure that I don't hold you up too long.
Let's spend just a moment going back to where we are on HIV therapy.
Yeah.
So I think that this is the year and the conference in the year that represents 30 years since the publication in May of 1993. May of 1983, my apologies, where the publications that led to Francois's Nobel Prize appeared in Science magazine. There were publications from her lab, from Bob Gallo's lab, from Max Essex's lab, and I think at least one or two others talking about HIV as the causative agent for at the time what became known as AIDS. Since that time, we have developed over 30 individual antivirals and fixed-dose combinations which provide life-saving medication to people around the world. If we just reflect on the success that we've achieved in that arena, it is pretty amazing. We've taken a virtually a guaranteed death sentence for people who are diagnosed with HIV and converted it into a chronic, somewhat manageable condition depending on other aspects of age. I mean, Steve was just in here, Steve Deeks was just here talking to you about the next big challenge. And the next big challenge is how do we then get to a near normal life expectancy with near normal expectations for life expectancy. But the next big step beyond therapeutics is applying the rigor that we had in therapeutics discovery and development to cure research. I think one of the most important things we had in HIV therapeutics is we had defined targets that were virus specific. We had the enzymes in the virus, and then we also had the CCR5 gene, which we know is dispensable for human existence, and so it became a target. So when we think about cure, we really have to get to those kinds of targets. We have the provirus, we have a cell. That's a good step to start, but we really need extensive research at the basic and bench level to define the targets that will lead us to a cure.
Right. Well, thank you so much for being here. It's always a pleasure to visit with you and to bring forward the science and make it understandable for the audience. That's important.
It's always a pleasure to be with you, and I guess we'll see you at CROI.
Yes, wherever that is.
Yes.